I'm going to be talking about two different studies that were done. The analysis of both were in my thesis. Hey, Lisa. So it's a mixed methods study. The first portion they'll be going through is quantitative, and the second one's qualitative, so you'll kind of get an exposure on both. Brief overview. I'm not going to read through the slides, so if you guys have any questions on anything, just holler at me. But the malaria burden, I think we're all pretty familiar with. The death toll annually is massive. It's estimated between 500,000 to almost 3 million. The burden of this in Africa is particularly heavy, so almost 90% of the deaths and infections that occur on that continent. It's also responsible for 2.2% of the global disease burden in terms of disability-adjusted life years. That's massive. In Kenya alone, that translates into 170 million days of work lost every year. So they have a population of 39 or so million, so that's significant. 19% of all deaths in Kenya, 20% of all deaths in children under 5, latest results from 06. So the role of drug shops, why we're talking about drug shops. By drug shops, I mean drug outlets. These are sort of what we would call a Walgreens or a Rite Aid, but in the developing world, it's a little wooden outhouse with a sign painted on the front. Maybe it's been open for 3 days, maybe it's been open for 3 years. The market is very fluid, so there's a lot of shop openings and closures that occur frequently. Presumptive diagnosis is regular practice in this area. What that means is malaria is so endemic. If you have a fever and that comes with malaise, you're going to assume that you have malaria. Patients will assume that, consumers of the healthcare system will assume that, and providers will as well. The problems that this causes is it leads to a pretty significant overprescription of antimalarials. These drugs are expensive, especially with the change to AL in 2006. The ACTs are more expensive, so we've got some overuse there. It also increases the risk of development of drug resistance. So the reason they switched from SP, which was the older drug in 2006, to AL was because so much drug resistance was found to SP that it's no longer really effective. And that happens when you give drugs, same as with antibiotics, to people who don't have the illness. There's also an increased risk of underdiagnosis of serious illness. If you're assuming they have malaria and they have TB or pneumonia, and you're talking about a kid who's 3 years old and they go untreated for 3 or 4 days, that could be fatal. So there's another component to problems with presumptive diagnosis. Most treatment for malaria is sought at retail drug shops. People don't really like going to the public health facilities. They have a little bit of a negative reputation on the ground, either because the workers there come from other communities, and so they aren't as invested necessarily in the community that they're working in, or there's been evidence of that. So people don't want to go there because they get maltreated, it's more expensive, costs a lot of money to get there, and they can get the same drugs at a drug shop that they can at the hospital, so why would they travel and expend the extra energy to get there? So for our purposes, understanding how a shop worker knows about antimalarials, their dispensing practices, their treatment practices, their interactions with their customers is really important to controlling malaria in this area, since this is where most people are going for treatment. So that brings us to the quantitative study. Our objectives here are to understand those factors. So what influences how a shop worker knows the correct antimalarials, and how does that knowledge affect their dispensing practices and their treatment practices, and even their diagnostic interaction with their customers. So this is our study area. This is Kenya, Western Kenya. This is the Bungoma district right here. And within the Bungoma East district is the Webuye Health and Demographic Surveillance Site. That's everything you see in color right here, this little section here. There are about 70,000 residents that live in the Webuye DSS. Their primary economy is subsistence farming, so each house will have its own little kitchen garden, chickens, things like that. There's also a sugar plantation in the area that some of the people that live there. So our methods were to identify all of the drug shop outlets in the Webuye DSS and accessible to people living within the DSS, which means up to 5 kilometers outside the border, because people might cross outside the DSS not seeing an invisible line there on the ground, telling them to stay inside. The survey tool was open-ended questions to shop workers. Some exclusion criteria would be if they didn't sell antimalarials in the shops, we wanted to make sure that we kept it malaria relevant. So this was the resulting population, 117 participants from 97 different outlets. Most of them were shops, as self-identified by name, so Webuye Clinic would be a clinic. And 95% were in rural areas, meaning outside of Webuye town itself. And even Webuye town, it's urban to them. So Chelsea's smiling at me. But that doesn't mean it's urban. This isn't Nairobi. It's still pretty rural, even within Webuye. But for the purposes of the study, we considered that to be urban. This is a picture of an urban retail drug shop. This is a little advertisement for an anti-malarial. These were the variables that were either identified in the survey or that I created as a result of the data. At the outlet level, if you have questions on that, let me know, because I'm not going to read through them. These are individual levels. So we really looked at everything from basic demographics to behaviors, practices, even perspectives and opinions, to some open-ended scenarios where they would be interacting with a mother with a sick child or febrile episode in an adult. Basic characteristics, overwhelmingly female, which was interesting. Bulk of which were between the ages of 30 and 40, so we're dealing with an older population, and you'll see in the qualitative survey following, or qualitative study following. The training was pretty well split between nursing or pharmacy. This nursing or midwifery, what that means is anyone that's self-identified as a nurse, nurse assistant, nurse aide, or midwife, we considered sort of nursing, just for the sake of simplicity. Pharmacy trained was pharmacists, pharmacy technicians, and pharmacy assistants. Most had over a secondary school education, two only had a primary school education, so fairly well educated compared to what's in the literature, but still not where we would want it to be. But this is the kicker. 15% of the people that responded said that they had a professional health qualification level but didn't have the education to match. I'm talking about somebody who said, I'm a clinical officer, and they only finished primary school. So that doesn't make a lot of sense. So in talking with some of the local people that work every day in this environment, the consensus was that people will self-identify in a role even if they don't actually hold that professional certification. So if somebody's opened a shop and to their neighbors and their family, they call them a pharmacist because they're working in a pharmacy, they may not necessarily be a pharmacist. So they may have only finished secondary education, but they're self-identifying. So you'll see some evidence of that later in the data. Antimalarial drug knowledge. So when the Ministry of Health changed the recommendation from SP to AL in 2006, we asked them, what is the current MOH recommendation for antimalarial? 65% could identify that. However, so that's just slightly more than half could identify the right medication. Of those, less than half would refer it to kids. So we'll see a little bit more evidence of that later on. The likelihood of knowing the right antimalarial is associated with health training. The odds ratio of over 3, pretty strong. Education was as well, but this didn't reach statistical significance. So it sort of lends you to believe that the professional health training might have more influence over identifying the correct antimalarial than education. We'll get into that more a little later as well. All of our little caveats are highlighted in yellow, so if y'all want to look straight to those parts of the slides, that's what that is. Assistant level staff are more likely than professionals, professionals being pharmacists and nurses, assistants being pharmacy assistants and nurse aides, are more likely to identify AL as the correct antimalarial or recommended antimalarial, but are less likely to have attended a workshop on malaria. So there's something else happening here that means somebody with a lower level of education or a lower level of health training has this information. A possible theory is that assistant training is shorter, 1 year, 2 years versus 3, 4, or 5 years. So they may have completed their training since the change in 2006. So they may have more up-to-date information, which sort of underscores a need to have continuing education opportunities for people who may have finished their training before the change to AL.
Andrea, can I ask a question?
Yeah.
Now, were these assistant staff, are they the same or comparable to the people who actually own the shop? Like, you gave us the demographics of those, like mostly women, 30 to 40.
Yes.
Okay.
Yeah, the demographics are largely the same. So that's when I get into the limitations, there is a limitation in this study that because of the sample size, we were only able to do univariate regression analysis. Otherwise, we were losing statistical significance when we introduced more variables, so we weren't able to control for some of the confounders. There's some gender confounding that you'll see later on, and some of that may play into this relationship, but largely The gender breakup is primarily the same. The focus between pharmacy and nursing is also similar, so they're pretty well representative. So behavior. Shop workers who refer children are more likely to recommend the correct anti-malarial medication to those kids over shop workers who decide not to refer and they just treat. You can go ahead and look at the other points because they're on similar scenarios, but the question that led to this data was a mother comes in with a sick child who's vomiting, has a febrile episode, and she requests Fanzidar, which is a brand name for SP, the outdated antimalarial. And the question to the shop workers is, what's the first thing that you would do? If that shop worker's first response is, I treat the kid, that shop worker also has a lower likelihood of knowing the correct antimalarial. If they refer the child either for a lab for testing, to a health facility for, either for the diagnosis, there's a higher likelihood. It's very difficult to identify causality in this relationship, but there is a relationship there, and it's pretty strong. The same thing with how they choose to stock medications and dispense medications. The two most frequently used responses to that question, it was either by customer demand or by Ministry of Health guideline. And again, if they stock by MOH guideline, they have a higher likelihood of identifying AL. If they stock according to customer demand, their likelihood of that knowledge is lower. But here we have our outlier again. 58% of shop workers who would treat that child with an outdated medication would know that it wasn't the MOH recommended antimalarial. So when you do an analysis of all of the people that correctly identified AL as a Ministry of Health recommendation, 58% of them would still give the mother Fanzidar. So we're underscoring a strong relationship of the effect that customer demand has on shop worker behavior. I know I'm going a little fast, I have a lot to cover, so. All right, access to quality care. So 100% of the workers that did not have any health-related training worked in rural clinics or outlets. 95% of those worked in shops rather than clinics. This is access to diagnostics, microscopic testing or rapid diagnostic testing, both of which are more available, still not greatly available, but more available in a clinic than a shop. Cutting blister packs of medications is not a great practice because you know that you're underdosing. The behavior of doing that is more commonly found among shop workers and clinic workers. And this one is the strongest. 92% of clinic workers would withhold Fanzidar from a mother who requested it, and none of them would dispense that medication to her. But in shops, 63% of them would withhold it, 19% would dispense it anyway. So you're seeing a bit of a variance in the level of treatment that you would get, or the access to care that you would have if you visit a clinic over a shop. There's also only 13 clinics in the whole study out of 97. So there's a shortage if you consider access to quality care as an issue. The gender dichotomy that I mentioned earlier, so men are almost 4 times more likely to have no training whatsoever than the women in the shops. Men are less likely than women to refer children and to recommend correct treatment, but are more likely to recommend correct treatment to adults. So there's a bit of a divergence here that it seems like female shop workers are diagnosing, recommending treatment, and dispensing medication more accurately in kids than men, which you could sort of say makes sense. They probably have kids of their own, right? But they are almost equal in identifying AL. So it isn't the knowledge of the drug that's influencing their behavior and how they treat their customers. So there's outside factors that we'll talk about in the qualitative part of the study that are influencing this relationship. And Puma, to your question earlier, there's confounding in here because women are more likely to be nurses than men.
Yeah.
And so if you were able to control for health training type, nurse, pharmacist, whatever, some of this effect will probably be lessened. So that is one of the limitations, univariate logistic regression. Only one geographic location. It's localized within the Webuye DSS, so generalizability may be a concern, particularly when you're talking about the breakdown of the demographics in terms of health training and education could be a geographically specific factor. And of course, all the data is self-reported, so whatever reporting bias would be a part of any survey. Any questions on the, yeah?
And the people, when you say they're referring, are they referring to another site that's also in your study? So like
No, so
in the shop,
would,
are they-
the question is if they would refer to a laboratory or to a public health facility.
so outside of the
Outside of the outlets, yeah. And in the qualitative part, when shop workers use the word refer, that will always be what they mean. They wouldn't refer someone to a neighbor shop. They would refer someone to a greater authority, if you would, a public health facility or a laboratory.
somewhere outside of the district that you're looking at?
No, the public health facility is in the district. It's just not included in the study. Any more questions on the quantitative? Anybody following? Were you lost or? Yeah? Okay. All right, so the qualitative study, what we're looking at here are talking to shop workers about their perceptions of using rapid diagnostic tests in their shops. So what we want to do is identify, would they see them as possibly profitable, feasible to implement themselves? How would their customers feel about it? Would they accept the test results? What factors might influence whether or not they're able to adhere and accept test results, be they positive or negative? So we conducted focus group discussions. You'll see the map is familiar. This is the Webuye DSS, the region within 5 kilometers of the Webuye DSS. Gives you a little bit of scale too, 5K, so it's a pretty small area. The focus groups were held locally, so co-located with the people that were invited to that particular discussion to try to increase participation. So discussion 1 was held right here in the Musihu Center, and this was the catchment area for that discussion. The community area was held here in the Musihu Village Center, same thing here, and then this is Webuye. This is the urban area. And you can see the concentration of shops much more dense here than, say, here. Bukembe is really, really rural, so that kind of gives you a little bit of the breakdown. So mapping using the same process that the first study used. There were many new locations that were identified and a lot of the previous ones that had already closed. These studies were about 6 months apart, so you can see the fluidity of the market there. Questionnaires were administered to participants before the start of the focus group discussions. This was a basic one-sheet education level, health training level, familiarity with diagnostic methods, MSTs, RDTs, age, and gender. They were conducted in Kiswahili with a Kiswahili fluent moderator from the region, and then translated into English. And then we used in Vivo 9 to enter and organize the qualitative data. So anybody who has questions about using in vivo, if you're planning on doing qualitative analysis, you could talk to me about that in the last hour as well. Really cool software. If you're doing qualitative analysis, I had a really great time with it, despite talking with Liz. Anyway, so we had 91 shops were identified and invited to participate in the focus groups. We ended up with 61 people. If the questionnaires are to be believed, none of those were from the same shop. So 61 individual participants from 61 separate shops. You'll see the slightly younger age group here, 66% between 21 and 40. More pharmacy trained than the previous study, and slightly lower education turnout. This is sort of interesting because this is the exact same population, the exact same map, the exact same, so we'll talk about that a little bit later. But this finding also came through in our study, and it was even more of a problem or of a concern. 5 out of the 11 pharmacists and 8 out of the 17 nurses had up to a secondary education. So this is pretty divergent. Very familiar with clinical diagnosis. That's what they use most often in their shops if they need to diagnose someone, and that's where they've had most of their training. Not a lot of exposure to MSTs or RDTs in this population. The identification of symptoms of malaria was really compelling here. They could correctly identify the basics, the fever, malaise, headache, things that we're all familiar with. But there were all these other symptoms that would be mentioned, like spinal cord pain, congestion, anorexia, that are not commonly related with a malarial infection. So there's some indication that perhaps the term malaria is expanded in this community to cover other ailments. One participant actually said that, well, malaria can come from anywhere, even a cut can cause malaria. So they're using the term differently than we would, which obviously affects diagnostic and treatment practices. So primarily symptomatic. How medicine is dispensed is under a lot of influence. They're supposed to only dispense medications when a customer comes in with a prescription. Obviously that doesn't happen. People will come in just needing care and will either request specific treatment or the shop worker will diagnose them and give them the treatment that they think is relevant. But there's evidence that even with a prescription, say the prescription is for a drug that's too costly according to the patient, the shop worker will take the liberty to change that prescription and dispense something else. But most of the driver behind that is coming from the customer, not the shop worker, at least according to this data. So it's the customer saying this is too expensive, I want something else, rather than the shop worker saying I think the doc doesn't know what he's doing and I'm going to give you something else. The use of antimalarials as a prophylactic showed up a lot in this data. So what they're saying, and they used the term prophylactic in English. I thought maybe there was a translation problem. There wasn't. That if they doubt somebody has malaria, there's some belief that somebody could have malaria that's not testable because if you don't have a fever, it won't show positive, or according to them, that's not true, but according to them. Or there's a phase where the plasmodium hasn't passed through the liver and they won't test positive. So in those cases, when they're testing negative, but they think the person might have malaria, they'll give them a prophylactic, which they think is less of a strong drug, has fewer side effects, won't do them any damage, but will protect them from getting malaria or protect them from the malaria developing into a full-blown disease. So interesting dynamic here. Possible motivation to make a drug sale, we don't quite know yet, but.
Which drugs are they using as a
There are a lot. I mean, a lot of them, based on the previous outlet survey, most shops had access to AL and would dispense AL. SP is still very, very common because it's so cheap. They're still using chloroquine, quinine, injectables, a lot of different possibilities. But I'd have to go back and look at the data, but I believe AL and SP were the two most common. So with this dynamic of doubting a diagnosis, referring would be a possible solution to that. But there's some resistance in this community to refer patients. One, because you're going to lose a drug sale. But more than that, back to that customer demand problem, they're refusing to go. What I talked about earlier. They don't have a positive opinion of health facilities, saying that people can even collapse while they're waiting in line at the district hospital. They may be taken advantage of. They'll prescribe the same drugs that are available in the shops, which puts shop workers in an interesting situation. You now have somebody who is demanding treatment. You're not able, according to regulation, to give them treatment without a prescription, but they refuse to go to a public health facility. So what do? You treat them, you send them to your neighbor who's going to make the drug sale because they're going to treat them, because the shop density that we looked at earlier, there's so much competition between shops that they're going to have to do something, and they'll always be able to get to the outlet where they can get the treatment that they're looking for. Back to the rapid diagnostic tests. Perceived benefits. I'll let you guys read these. But something that was interesting that came out of this is when you have testing done in a laboratory at a hospital, you're not able to access the results. You have to take it on the lab tech's word that you are positive or that you are negative. With an RDT, it looks like a pregnancy test. It's like one blue line and you're negative and two blue lines are positive, basically. And they can show the customer that in the shop. So they felt that there was an increased customer confidence in the diagnosis and in the subsequent treatment, because they have that access, which they wouldn't have at a health facility. Challenges, cost, why would I pay for a test when I don't have enough money for the drugs? That's going to be a clear argument. Fear of RDTs. You've seen this in literature before. People have a fear that you're testing for HIV. There was even some concern that there's a government conspiracy that they're using RDTs to force HIV testing on the populace, or that would be a concern. And you'll see an urban and rural dichotomy here, which I'll talk about a little bit later, that people in rural areas have less access to healthcare and less exposure as a result. And so there are people that may have lived their entire lives without ever having seen a needle. And you show up with a lancet and you want to prick their finger and they're going to tell you, I'd rather die than be tested. But again, perceptions of the shop workers. We'd have to corroborate that with the community, but this is the perception. They were very, very adamant that RDTs are not sold directly to customer bases for them to use at home. They might be a drug sale loss issue happening here, but also misdiagnosis if they misuse the test. I'm going to save a point for a little bit later on. about that, but that's right here. Acceptance and adherence. Because you have a presumptive diagnostic culture with malaria, if a mother comes in and she thinks her child has malaria and the test is negative, she's going to think you're nuts, frankly. This is another possibility, that if they don't accept the results, some will immediately think it's witchcraft. How can the child be sick and there's no malaria? This was new to me. I didn't see a lot of evidence for witchcraft in this community, but in the rural areas it's there. And shop workers are very concerned that mothers would, with a negative test, then and go and visit a bunch of different witch doctors with their child, delaying treatment of that child and causing the child harm, if not death. Customer resistance will put pressure on shop workers because of the influence that they have over them. Shop workers may doubt the results both in negative and positive tests, as I mentioned earlier about plasmodium passing in the liver and those kinds of things. So there's an education opportunity here. And then they had very strong opinions about how to implement this correctly. They've seen a lot of implementations in their community. The Ministry of Health sending trucks that have microphones, calling out messages through the streets, or they'll paint the side of a building with an advertisement for a clean water system or something like that. So there was a lot of positive energy around getting involved in an implementation and how to make it feasible in the community, which was great to see. This is the urban-rural dichotomy that I mentioned. Rural. This is the Bukembe Deliverance Church. This is where we held the Bukembe region focus group discussion. That's my public health officer right there, Emily. The dichotomies here, so rural customers seem to have access to shop workers that urban customers don't have. They'll visit them at home. They'll call them in the middle of the night. They'll pay on credit. They have a more intimate, it seems, understanding with each other than you will see in the urban centers. Rural clients were also the ones that had an exposure to needles, maybe practicing more witchcraft and things like that would benefit from a community health education program. Just in contrast, so rural, urban. This is the Wiguye DSS office. It's on the Wiguye District Hospital grounds in the Wiguye Town Center. That's where we had our two urban discussions. Urban shop workers had a higher level of education, had a higher level of professional training, although not by a lot. I mean, 10 to 7% is not a lot. More likely to recommend medications rather than just dispense them, taking ownership over the diagnostic process, but again, not by a lot. Influence of competition, I mentioned this briefly earlier. With shop density, patients know that they can just go somewhere else to get what they're looking for. Shop workers are motivated to distinguish themselves from their competition through certifications, qualifications, offering diagnostic services, just like you would see here. They want to sell it for less. They want, to advertise that they have services that their competitors don't have. So there's a motivation to diagnose and treat accurately. People were talking about how if you mistreat someone, either emotionally or with the wrong medication, they're going to go and tell their friends and family, don't go to the shop. His drugs are expired. He made me ill, whatever. So there is an invested interest in getting more training and treating their customers as well as they can. We've talked about a lot of this already. So some of the limitations for this study focused exclusively on shop worker perceptions. There's a great opportunity here to do a follow-on focus group discussions with the community, especially mothers of sick children, to see if they corroborate one another. Is what the shop workers are saying about the perceptions of customers' behaviors accurate? Do the customers have that same perception of themselves and of shop workers? It would also help provide more input into an RDT implementation, which is the ultimate goal here, is to make this change on the ground. But before you can do that, as you all probably already well know, you need to have that information as to how to make it relevant, how to make it feasible, how to make it effective, get key opinion leaders involved, elders in the community, the Ministry of Health. There's a regulation issue here because shops aren't typically allowed to do diagnostics, so there would need to be some involvement with the Pharmacy and Poisons Control Board of Kenya to make that happen. And that's all what's listed here. I am going to highlight this because I think this is pretty fascinating, because patients have such a strong influence over the behavior of shop workers. If you educate the community on appropriate malaria treatment, appropriate identification and diagnosis, you can use that power that they have over the shop workers in a positive way and get them to demand AL rather than SP, get them to demand diagnostics before treatment and leverage it, which I think is a great opportunity. Like every study, people come out of the woodwork to pull stuff like this off. Moy Teaching and Referral University and Hospital is the hospital in Eldorette where I was living. This is the Webuye DSS group that conducts regular surveys of the community and got me entree into the Webuye DSS. USA and AMPATH operating in Eldorette, Indiana University, who started that relationship. The Hubert Jurgen Center, for getting me to Kenya. And the DGHI for all of the funding, support, faculty, and my friends and family who have listened to this more times than they probably care to count. That's it.
Yeah.
What you got? 12:30. Yeah.
You might have covered this, but did all of the shopkeepers already know about rapid diagnosis, or did you do any sort of education, or what was the education like?
So when we started the focus group discussions, one of the first questions was, do you have any familiarity with RDTs? And overwhelmingly they said no. I mean, based off of the questionnaires that we deployed, not to mention the quantitative data that was collected the year before, very little exposure to RDTs in the area, maybe one per discussion and probably not even that. So what we did is, after we had the questionnaire, we had this basic preliminary, where are you in terms of diagnostic knowledge, we did a demonstration of an RDT. So we brought in a lab tech from Webuye District Hospital who came in with a sample. He would prick one of a volunteer or himself and actually conduct the test right there, show them how it turns negative, show them all the components that are involved so they can see how the thing operates before they could comment on whether or not they would think it would be profitable and sellable. So that was a major concern going in.
So I was interested in the perception that RDTs might be a secret government conspiracy to test for HIV, because actually we've run into the same thing in villages in Tanzania.
No kidding.
And so two questions. One is, was that the perception of shopkeepers, or did that reflect what they thought their customers might think?
That's what they thought their customers would think. But the line between that is really fuzzy, because in a focus group discussion like this, a shop worker may say, my customer might be concerned that this is what's happening, when that's really their concern, because they are also customers of the healthcare system and would be possible. I mean, they did talk about using RDTs because they're so simple on themselves and their own family when they encounter a febrile episode personally. So it's hard to differentiate that, but it was under the heading of, this is how I think my customers would react.
And did this come across as a major issue, or was it just a comment?
The conspiracy part was mentioned by two people in two different groups. So some corroboration, but definitely not the norm. There was a lot of concern, though, that customers would have issues with having blood drawn in relation to an HIV test. That did come up frequently. Not the conspiracy part, but the HIV part. And needles in general was even a bigger issue. There was some finding that would contradict that, to say, oh yeah, it's like a diabetes test. Or, they're going to be familiar with this, but I think that's where the urban and rural dichotomy shows up, is because that was really only in the urban areas. Does that answer your question?
So you talked about the relationship between the patient or the customer and the shopkeeper, but what about the relationship between Ministry of Health and the shopkeeper? Did they have also that similar distrust, or was that an influencing?
Absolutely. There's some pretty significant, I would say, gap in understanding between the regulatory agencies in operation in the area and the shop workers. We didn't ask people if their shops were registered or not registered, because it's illegal to operate in an unregistered shop, but there was clear evidence in the discussions that they were working in shops that were not registered. But there's other parts of that story. It's cost prohibitive for most of these people to register their shops because it's so expensive. You have to pay annual dues. You participate in an auditing process. So inadvertently, the Pharmacy and Poisons Control Board is almost placing people out of registration because it's so expensive and it's such a time commitment. So I think that if the registration process were feasible, there would be more of a compliance rate than there is now. But there is a lot of distrust. People would talk about, I don't want to sell RDTs, or that public health officer is going to come harass me. She might even shut me down. Or this dispensary next to me doesn't offer testing. If I start offering testing, they're going to try and shut me down. So there's this almost combative relationship between the public sector and the private sector. Anything else? Yeah.
For the focus groups and the survey, like the qualitative and the quantitative parts of your study, which one did you do the qualitative after the quantitative, and like what was your strategy? Like why did you decide to do it that way? Were they interrelated?
So, great question. So the quantitative survey had been designed, written, and implemented by Wendy O'Meara, my mentor, and Nathan Smith, who was an NPH candidate working for her at the time. This was in 2010. So they implemented the quantitative survey. They collected the data, and then I conducted the analysis in 2011 in the spring before the start of the qualitative study. So those findings, looking specifically at the exposure to RDTs, brought the question, how come they don't know this much about RDTs? Is it even feasible to implement them? And that's what started the qualitative study. It was after that I finished the analysis on the quantitative portion for the results that you see here. But it was sort of the next natural question, like getting the communities involved that we member. Why don't we guess together? More answers, more questions. Yeah?
You mentioned the divergence in terms with like the term pharmacist and people identifying as that and some other terms. Did y'all do any work on that before the survey, or how did you look at that?
Well, we didn't really identify that as being what's actually happening until we analyzed the data. It was when we got the questionnaires back and we saw there's no way that there's a clinical officer who only has a primary education, and there's no way we've got 15 nurses and only 5 of them finished secondary school. And that's when I started to have conversations with my study team in Webuye saying, can you think of what might be going on here? And that's when they started to bring up these possibilities that they have these roles in the community, and that's what's being reflected in the questionnaires. So I hadn't seen any evidence of this in the literature up to this point, so this was all new to me. And I think I agree with the answer. I think I'm fairly confident that that is what was happening. Now, there's always a possibility that they misunderstood the question, but to have answered every other question accurately, it's not a language barrier, so I think there's a likelihood that that's what's playing into it. We didn't do any pre-work on it. Never anticipated it.
It just kind of made me think, more of a comment than a question, but it made me think of like my experience in Kenya, where you have people who understand certain pharmacists to be quacks, and they call them quacks, and they know, okay, this guy's a quack and that guy's okay, and they will kind of self-select into these different, pharmacists or clinics or whatever. It'd be interesting to know that you've included the people who quite possibly are perceived as the quacks into your study, and perhaps those are the people that are coming up with answers like this.
It's possible. It's entirely possible. But I think there are, at least I found some evidence that there are some people working in these shops that have quite a high opinion of themselves.
Right.
Some people would say, the community think we're doctors. We basically are doctors.
Yeah, they do think that, yeah.
The customers may think that. They may think that of themselves. And when you see them overriding prescriptions or even diagnosing someone, you have to have a measure of, arrogance is not the word, but self-confidence or so to say, I'm going to identify your symptoms, I'm not going to refer you to a public health facility, and this is, and I'm going to basically act like a doctor. So there is evidence of that they kind of have that opinion of themselves. So if somebody like me, or my moderator, who is even from Kenya, is going to say, what's your health qualification? We'll be like, I'm a pharmacist.
Yeah.
Fully possible. Not to mention, they're in a group with their peers.
Right.
Everybody completed the questionnaire privately. We didn't discuss that. But when you're sitting next to people who are your peers, your community members, and your competition, there might be a draw to maybe fill in the next higher bubble on your sheet. It's possible. Any implementation questions, maybe from the new cohort on development? You don't even know where to begin yet? All right, we can talk about that separately.
Time.
I think that's it. Great. Thank you very much.